We'll probably wait a few more minutes to see if anyone else is joining, or we'll start. Okay, I have like three clinical stations to do. If anyone wants to volunteer, can do. So the difference in clinical station is that obviously we are not going to do it on a patient online, but then the importance of doing it verbally, like what we are doing now, is that it will help you understand the flow of the station. Only if it is there in your head, you'll be able to do it quickly on the patient, because you only get like 4.5 minutes of examination compared to what we usually get in our post graduation, for long case or short case. Like you get like 40 minutes with the patient, or like 20 minutes with the patient, wherein you can like sit and patiently, slowly examine and think about the findings and all. But the difference here in MRCPCH clinical exam for clinical station is that you just get 6 minutes with the patient, in which, developing rapport with the patient, exposing the patient, all that takes up almost 30 seconds to 1 minute. So you essentially only have like 5 minutes to examine. So only if you have the flow in your head, to know what to do next, and also that if there is this finding along with this finding. For example, if A plus B is there, that means it is C. So your mind should be, immediately able to gather all that information and able to summarize. Because as soon as the 6 minutes is done, you'll have to start summarizing for the clinical station, because immediately after 6 minutes will be 3 minutes of discussion. They don't give you any time at all to gather your thoughts about the examination findings or anything. For that reason, to get the actual flow, doing clinical stations online will be actually very good. So we do have our website, targetmrcpch.com, where you have, you can even download our app, and we do have all our active courses right now. We'll be starting a new course also. That's what I've put here, that we are planning for the further diets, diet 2 and diet 3. You can contact the number that's given below. If at all you are an Apple user, iPhone user, then it will usually ask for an organization code that I've displayed here, that you can apply while downloading the app. So anyone wishes to volunteer today for the clinical
Yes,
station?
ma'am.
Dr. Sam Suzaman. Okay.
जी.
So I guess you're familiar with the timings for clinical station. Usually there'll be 4 minutes during which you'll be sitting outside the station. You won't have any information at all about the clinical station. You wouldn't even know what system you're going to about to examine when you enter the station. After the 4 minutes is done, a bell will be given, after which you'll enter the station. So the moment you open the door or the moment you enter the cabin, time will start. It is not like you go get the command, after that the time will start. It's not like that. The moment the bell rings, the time starts for 6 minutes or the entire 9 minutes. So then you'll have 6 minutes for examination, followed by a warning knock or a warning bell, depending on the center. And then we'll have 3 minutes for discussion. Usually, even though they tell you that there is only 3 minutes left, the examiner doesn't usually stop your examination. If at all you're continuing your examination, they just let you examine. And then once your examination is done, it goes on. But due to want of time, we would recommend that you guys don't, take up the next 3 minutes of discussion time also in your examination. Try to keep your examination within the time limit of 6 minutes, so that you'll have enough time for discussion. Because discussion also carries as much marks or even more marks than your examination. The main marks for examination is you do the structure of examination, how it is, and they give you 2 marks for that. Identification of clinical signs is another 2 marks. And then, for 6 minutes, you only get like 4 marks, if at all. And then the next 3 minutes during which your discussion happens, you get the remaining 4 marks, wherein you do communication planning, management planning, and your investigations and all that. Interpretation of clinical science and management planning takes two marks, 4 marks during the next 3 minutes. So it is equal. The 6 minutes also gives you 4 marks, and then the next 3 minutes also gives you 4 marks. Sometimes even the identification of clinical science comes in the next 3 minutes. So almost 6 marks comes from your 3 minutes. That's why you'll have to be very quick in your discussion. Your discussion has to be very crisp. You don't have to answer in length at all, because you won't have enough time. Hope the timings are clear for the clinical station. So since the 4 minutes outside usually doesn't have any information at all, we can probably jump into the 9 minutes if Dr. Zuman is okay.
Yes, ma'am.
Zaman's okay. Yeah, okay.
Will I open my camera?
Yeah, you can definitely open your camera. If at all you have a doll or something on which you can examine, then you can do that also. Whenever you're ready, I'll start the time and start the command.
Yes, ma'am.
Okay, in your camera, I'm not able to see you, doctor.
Okay, okay, sorry. Now,
No, now also I'm not able to see you.
um, is
If
it okay now?
if you can bring the camera a little bit down, then
Okay, okay, sorry, sorry. Okay, ma'am.
yeah, sure.
Let's.
Yeah, or you can probably do it without the camera also. That is also fine. Whenever you're ready, Dr. Samsu, we can start.
Ma'am, now okay?
No, it's still the same. So, like I said, maybe we can, do it even without your camera. That is also fine.
Okay, ma'am. Okay, okay. Sorry for.
Okay. No, no, that's okay.
Okay.
So you'll have 9 minutes to do the scenario, and your time starts now. So this is Tom, who's 8 years old boy. Examine his lower limbs for motor system. Hello, Dr. Samsu Zaman. Are you there?
Yeah, yeah, ma'am.
Yeah. So you can start verbalizing as though, you're going to examine. You can start verbalizing.
Ma'am, please. I have not seen fully
Oh, you
the
didn't see.
command.
Okay, fine.
Yeah,
1 second.
Tom, 8 years old boy, right?
So this is an 8-year-old boy, Tom. Examine his lower limbs for his motor system. Usually in
Okay,
exam also, they won't show you anything at all. It is just the oral command that the examiner tells you. It is not like you'll have a paper in which, they'll give you the command. So whatever I tell you, you'll have to do according to that.
okay,
Yeah, please
okay.
start.
Hello, good afternoon. I am Dr. Jaman.
Hello,
Here
good
is
afternoon.
my mark sheet, sir.
Yeah,
Okay.
this is
Yeah,
Tom.
good afternoon.
You can start examining him.
Okay, thanks a lot, sir.
Yeah.
Good afternoon, mom. I am Dr. Jaman, one of the child doctor here. Today, I will look Sam's his limbs and involve doing something with this hammer. Is it okay for you and Sam, ma'am?
Yes, doctor, sure.
Okay. Sam, how are you? Good afternoon. I will see what Sam is currently doing. Is there any dysphoric faces, distress devices attached and appropriately grown for his age or not?
Good afternoon, doctor. So Tom is just sitting on a chair.
Okay. Is there any distress,
No, he's not in any distress.
any device,
No, you don't see any devices around him.
any dysphoric faces?
No, there's no obvious dysmorphism that you can see. No.
Okay. Looks appropriate to his age.
He looks thin built slightly for his age. Otherwise, he looks okay.
Okay. That's good. Tom, how are you, Tom?
Tom says, yes, doctor, I'm fine.
Okay. I will see. Is there any difficulty in speech, these are three or not?
Difficulty in? Sorry?
Speech
In
difficulty, these
speech?
are
No,
three
he's
are.
not having any difficulty in speech.
Okay, Tom, can you please stand for me?
Can you please?
Yeah,
What is it? Sorry, I
stand. So, can you please stand for me?
You want him to get up, is it? Stand up.
Yeah, yeah.
Okay, so from his chair, he's getting up.
Okay, I will see. Is there any special shoes wearing Tom or not?
No, he's not wearing any special shoes.
Okay, I will put off Tom's shoes. Okay, Tom, you look very good. I will put off your shoe. Okay, I will put off the shoe and we'll see any high arch sole or any uh, hypertrophy, muscle atrophy, joint contracture, or any abnormality is seen in lower limbs.
Okay. You can see this when you look at Tom.
Okay. Okay, Tom. That's you are doing very good. Okay, Tom. Tom, can you please walk for me? Is Tom able to walk?
Okay, yeah. So he says okay, and then you can see him walking.
Okay, Tom, you are doing great. Tom, can you please put together your both legs and stand? I will do the is rhomboid sign is present or any cerebral sign is present or not.
So you can skip that. You don't have to do that. You can skip that.
Okay, that's great. Tom, we'll sit together. Okay, Tom, you are a very good boy. Tom, can you please sit for me?
You want him to lie down, is it?
Yeah.
Yeah, he's lying down on the couch.
Okay. Okay, Tom, great. Can you please now stand up for me? How is he standing up? Is he squishing both of his legs?
Yeah, he has to hold to both of his legs to get up.
Okay, okay, Tom, you are doing very great. Okay, then I can, Tom, can you please lie down for me on the couch?
Yeah, he's lying down on the couch.
Okay, okay, great, Tom. You look very beautiful. I will see the muscle, muscle bulk, and I will see the muscle tone.
Okay, for bulk, the only significant thing that you can see is this, what you already
Yeah,
saw, you already
calf
observed.
muscle, yeah,
Yeah,
pseudo
tone,
hypertrophy,
you feel that tone is reduced in all the four limbs.
power, and I will see elicit the power of both lower limbs.
Okay, when you see power, power also seems to be reduced. It is about 3 by 5 in all four limbs.
Okay, okay, Tom, you are doing very great. I will elicit the jerks, knee jerks, ankle jerks. I will put the hammer. Uh, Tom, I will just stroke on with it. Okay, Tom.
Yes, doctor, sure.
Okay, I will see the jerks reduced or normal.
Yeah, you feel that the reflexes are not that brisk. It is actually reduced only.
Okay, okay. I will show my finger, index finger. Tom, I will just stroke your latter, the side of the leg, toe. Okay, I will see the plantar reflex. Is it
Okay.
okay?
Okay, plantaris flexor.
Okay, then I will see the uh, um, uh, mm, uh, clonus is present or not.
Okay, your 6 minutes is over. You have 3 minutes left. No clonus you can elicit. There is no
Okay,
clone.
then I will see in coordination test, is it able to do or not?
Which one? Which test?
Coordination, lower limb.
You don't have to do that. You can skip that.
Okay, Tom, you have done very great. Thanks a lot, Tom. I will put on the pants of the Tom and give him thanks. Now, in present the case,
Yes.
today I got opportunity to examine Tom's both lower limbs and Tom looks a little bit uh, um, undergrown to his age. Although I want to take his height and weight and put in appropriate growth chart, no dysphonic faces, no devices attached, and there is Gower sign is present while Tom is trying to standing up from sitting position. Also, waddling gait is present, and on observation, there is pseudo muscle hypertrophy is present on the calf muscles, and there is jerk is diminished, muscle tone and jerk is diminished bilaterally. Uh, putting this together, I have I have some references. Most probably, it is a myopathy.
Okay. Any differential diagnosis that you want to give?
Most probably, uh, uh, a muscular dystrophy, that is Duchenne muscular dystrophy, uh, uh, or other kinds of muscular dystrophy, or spinal muscular atrophy type 3.
Okay, okay. So how do you want to manage Tom?
I want to involve my senior consultant, pediatrician, and pediatric neurologist, and also occupational therapist, physiotherapist, and also uh, 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 rehabilitation therapist.
Okay. What is the multidisciplinary team that you would want to involve?
I want to involve the pediatric neurologist, pediatric rheumatologist, general pediatrician, and occupational therapist, physiotherapist, and if there is a progression of the disease and chest involvement occurs, then respiratory physician, and I also want to involve pediatric cardiologist.
And what advice would you want to give to parents?
Sorry.
What advice would you want to give to parents?
Okay, I want to and also want to involve the genetician, and I want to give the
What
parents about the.
advice, what advice would you want to give to parents?
Okay, this is a progressive disorder, and with the multidisciplinary team help, this disease will be progress slowly, and doing regular physical activity and physiotherapy, the disease will be a slow progression, and I will give some antioxidant and and if there is any warning sign, respiratory distress, or then surely contact with us immediately.
Okay, okay, fine. Yeah, your time is over. Okay.
Thank
So
you, mom.
overall, what you did was very good, Dr. Sam Zaman. You were able to, follow a format in your examination. Your rapport was very good, how you were talking with the patient. And your differential diagnosis, your discussion part, everything was very good. It was a very neat presentation. Uh, so once the gait, what were you able to find, what was the type of gait that you saw today in the patient?
Myopathic gait or waddling gait.
Yeah, it was a Wadling gait, is very good. And your differential diagnosis was also very good. It was a muscular dystrophy, putting distance as the first DD. But you can also do, Becker's muscular dystrophy as your other DD, because especially because the child is still 7 years and, doesn't seem to have very severe disease. So this can even be a milder form of the muscular dystrophy, which is Becker's muscular dystrophy.
Yeah,
And
yeah.
the other lower motor neuron. So the only thing is, whenever you, tell that it's Wadling gait, and then you want to give differential diagnosis, what we usually say is give an umbrella diagnosis, so that you can give a wider range of differential diagnosis. Like this is a lower motor neuron lesion pathology. That much you tell, and then your differential diagnosis can be muscular dystrophy or muscular atrophy, whatever you want to put after that. Yes. Hope I'm clear with what I said. Usually try to give an umbrella diagnosis.
Okay, ma'am. Thank you so much.
Yeah, thank you, thank you. Otherwise, your multidisciplinary team, everything was very good. In advice to give to parents, one more thing that you'll have to tell is that they'll usually be given an alert card. So this is an alert card that is usually given to patients. This is devised by the Muscular Dystrophy Organization of UK, wherein the name, date of birth of the patient, and whatever NHS number, identification number that they have, and if the child is presenting to the A&E with any difficulties or any of the severe symptoms, then which number to contact, because the specialist team has to be contacted and inform about the child presenting, so that they'll know the action plan or the management plan for the patient that has been put forth. This alert card also has all the complications that can be expected in the child, and what to do for those. For example, in gastrointestinal, we'll have to avoid NSAIDs, as it can worsen their GI issues, especially for long-term steroids. Like that, they've given all clinical clues. Anesthetic precautions, they should avoid succinylcholine here, because they are more prone for respiratory failure. Respiratory failure is actually said to be one of the very most important cause of death in DMD. because of high risk of acute rhabdomyolysis. So like that, all these are given here so that if at all the patient has gone to the hospital for something else, they can refer to this alert card, and the patient can be, treated accordingly or managed accordingly. This alone, you'll have to add extra in your advice to parents when you are talking about the disease.
Okay, ma'am.
And
Thank
then
you. I
this they
will
can
do
ask you
noted.
what pharmacological management do you want to do. Usually we start steroids to slow or tether the progression of the disease. Similarly, they can ask you any newer drugs that you know for DMD. Usually they say Ataluren can be used. No, Ataluren can be used for DMD. It is a newer drug for DMD. If at all time permits, then they can ask you all those questions. But usually 3 minutes will be a very, constricted time for discussion, because you'll also summarize during those 3 minutes only. So try to keep your summary as small and crisp as possible. If no one has any doubts, then we can probably move on to the next station. If anyone wants to volunteer. Any doubts, you can definitely unmute yourself and ask me. Okay. Thank you, Dr. Sam Suzuman. We'll probably move on to the.
Thank you, ma'am, so much for giving me the chance.
Thank you. Thank you. We'll move on to the next station. Anyone else wants to volunteer?
Okay, ma'am, I can be a volunteer.
Dr. Mala is sure. So next will also be a clinical station. Hope you are ready. Shall I start your time?
Yeah, ma'am.
Like I said previously, we'll cut the 4 minutes. We'll just directly jump into the 9 minutes for clinical station. Your time starts now. So this is 8 years old boy Jack. Do a gentle physical examination and proceed for him.
Okay, I enter in the room and I hand over mark sheet to the examiner and I take permission from the mother as well. Can I examine the Jake today?
Yes, Dr.
Hello.
Sure.
Hello, Jake. How are you?
Yeah, Jack is not responding that well to you.
Okay,
He's
then
just
I
looking at his mother.
okay, then I will sanitize my hands and I will come at the level of the Jake and I'm looking on the face for any dysmorphic features.
You can see whatever is there in the picture.
Okay, any sign of distress?
No, he's not in any distress.
And in this picture, no any device is attached, so I can commit no any device is attached. And what about any surrounding? Like what about dimensions? Means his height and weight is putting on like
Yeah,
on the
Jack is sitting in a wheelchair. He looks very short for his age and slightly stout.
okay. So I'm coming at the level of like hands. Jay, can you show me your hands?
Yeah, he's showing his hands.
Okay, I'm checking on the hands like the for any pelarness,
No, there is no pallor.
any coloring, and the nails.
No.
Okay. Okay, then I'm coming at the level of like the radius, like radial pulse. I'm checking. So how's the pulse?
Yeah, the pulse rate is about 90 beats per minute. Good volume.
Okay. Good. Okay. Okay, Jake. So I'm checking at the level of the arm and forearm. Any rashes are there? Are any cannulation marks?
No, no.
What about the BCG scar? Is BCG scar is there?
Yeah, BCG scar is present.
Okay. Then I'm coming at the level of head and I am checking for any like swelling or any like the something is there. For I'm checking for the FOC, fronto-occipital circumference. So what is the FOC of Jake?
You don't
With the
have to mention
measuring term.
the fronto-occipital circumference, but when you look at him, the head looks slightly larger.
Okay, I'm coming at the level of eye. So can you, Jake, can you like put your this hands like me and putting the lower eyelids and below? Then I'm checking for the any like a paleness or any like the yellowish discoloration.
No pallor, no yellowish discoloration.
Okay, and what about when I'm saying about the any seeing for the nose, any nasal discharge or any nasal polyp?
Yeah, you can see there is nasal discharge.
Okay, fine. Jake, can you open your mouth like
He is actually not able to understand what you're telling, but you can open his
okay,
mouth and see.
okay, then I am. Yeah, so I'm checking for any gums, like any hypertrophy or any like left lip or palate or any high arch palate.
Oh, but you can see that there is, mal positioning of teeth. You can even see serrated teeth.
Okay. Okay. Then I'm coming at the level of the chest. Any epictus, excaptum, or cinatum. I'm taking for the chest deformity, and I'm taking from the help from the mother. Can I expose the jig?
Yeah, you are exposing Jack. In the front, you don't see any obvious chest deformity, no.
Okay. Then I'm coming at the level of the abdomen. So any abdominal distension is there?
Yeah, you can see that abdomen is slightly distended, especially in the
Oh,
upper part of the abdomen.
upper part. Okay. I'm checking for the liver. Is liver is there?
You want to palpate, is it?
Yeah. Yeah. I'm palpating the liver from the right iliac fossa towards the right hypochondrium.
Yeah, liver is palpable.
So I'm checking liver consistency and borders and as well as liver span with the measuring tape. So what is the liver span?
Liver seems to be firm, smooth surface. Liver span is about 12 centimeters.
Okay. And what about any spleen? I'm checking for a spleen and the
Yeah,
oblique
spleen is
veins.
also palpable. It's
So
palpable
how?
about 3 centimeters below the left costal margin.
Okay. I am checking for the kidneys biminally palpate. Is there
No, no,
kidneys?
kidney is not palpable.
What about the umbilicus? Is umbilicus is slit-like or the distended? What about?
No, it's inverted.
Inverted. Okay. Thank you. Then I'm coming at the level of the bake. Is bake is fine? Any kyphosis, any lordosis, any spine deformity?
Yeah,
Jake,
when
you are the good boy.
you can see this, this is how his back is.
Okay. Yes. Okay, and I'm checking for the knees. Is there like knee bowing of legs is there or not?
No,
Okay, and what about any feet? Any edema?
no.
Okay, and then I'm checking for the short stretcher maneuver. Like, can you put your hands front of the knee? Is he able to put like?
Yeah, he can do that. You
And
don't
when
see
I
any obvious asymmetry.
no any asymmetry.
No, no asymmetry.
Okay, then I'm saying like, can you make a star?
Yeah,
Is
he
it?
is making a star.
And can I say like put your thumb on the shoulder? Is he able to put on the thumb on shoulder? I'm checking for the any upper to yeah, like this.
Yeah, he is able to do that.
And I'm checking for upper to lower arm span. Is it fine?
Yeah, he is doing it like this. The thumb finger is touching the shoulder like this.
Okay, when I say like put your arms like below, so it's on the thigh or on the mid thigh?
Yeah, he's putting the hand on the side of the thigh. You feel that the hands are reaching almost his knees.
Knees. Okay. So yeah, I'm checking for also like yeah, forearm. Make it start. Yeah, I'm saying like the for any what angle is there?
Sorry, what
Cu-
do you want?
Yeah, I'm checking for the cubitus something. Yeah.
Cubitus valgus, you're telling.
And yeah.
Okay, no, there is no cubitus valgus.
Okay. Okay, so I am checking at the level of chest to see any apex beat, and I will auscultate the chest to see any murmur.
Okay, you have 3 minutes left. When you're auscultating, there is no obvious murmur.
Okay, so I want to complete my examination by checking the anthropometric measurements on a centile charts, and I will check the blood pressure and also the genitals as well of this child.
Okay.
So today I've examined an 8-year-old Jake who is who is sitting on the wheelchair and no any sign of the distress, but he has like some dysmorphic features in the form of frontal bossing, nasal deformity, and some fullness of cheek as well. Some coarse facies means, and he is like a good like the what we call 90 beats per minute pulse is there, and some now nasal discharge. But when I examine the abdomen is distended and liver is palpable with a liver span of some 6 to 8 centimeter that is firm and smooth borders, and spleen is also palpable that is 3 centimeter below the left costal margin. Rest of examination is unremarkable. On the back, some kyphoscoliosis is there as well.
Okay, so based on your findings, what differential diagnosis do you want to give?
Yeah, on the basis of this, I will put on the top like some storage disease like mucopolysaccharidosis, gangliosidosis, and hypothyroidism as well.
Okay. Okay. How do you want to manage Jack?
Yeah, first of all, I will manage by reviewing the previous record is available or not. Then I will do the diagnostic test is like a urinary glycosaminoglycan and somehow like the basic labs like the complete blood count as well and the urea-creatinine electrolytes. Otherwise, on the basis of this, because patient is a coarse facies and some of kyphoscoliosis, so I will do the spirometry for any like restrictive lung disease, and I will manage this case by involving multidisciplinary approach like a consultant pediatrician and metabolic team, orthopedic team, and genetics, pulmonologist, and physiotherapist, and liaise with the school as well, and psychologist and support to family because patient is a short stature and maybe development delayed because when I answer question them, they do not answer. And I will advise about like genetic counseling because this condition is autosomal dominant and avoid the trauma and
And
vigorous
what will be
exercise.
your follow-up plan for Jack? Follow-up plan.
Yeah, I will follow up like the to see the some test like the sleep studies, and I will check the cherry red spots
Okay.
and X-ray and echo as well.
X-ray neck is for what?
Yeah, because these patients is recurrent chest infection, so I will do the chest X-ray
Chest X-ray. Okay,
and
okay.
echo because of short neck. Yeah, echo because of short neck because of these patients have obstructive sleep apnea to rule out this.
What can happen because of obstructive sleep apnea, cardiac complication?
Core pulmonal happen.
Okay, fine. Yeah, your time is over. Thank you, Dr. Mala.
Thank you, doctor.
Yeah. So like you said, it was mucopolysaccharidosis only. Usually general physical examination proceed comes in other station. So it was a very good presentation that you did today, Dr. Mala. How you approached the child, how you inspected the child and then had your findings, you picked up all the findings. That was all very good. Usually what we say is in general physical examination proceed, just do a complete inspection from the front, from the side, from the back of the patient to find out if there is any clinical clues that you can identify based on which you can proceed. Usually, general physical examination is that you'll have some clinical clues on inspection of the child, and then based on that clinical clues, you'll have to proceed with your examination, do a systemic examination or relevant examination, like Dr. Mala did today. So she was able to pick up core species. Most probably, it should be mucopolysaccharidosis. Hence, we expected the child to be short. So she did short stature manövers to find out what type of short stature it is. And then she also did hepatosplenomegaly examination because HSM is, hepatosplenomegaly is expected in mucopolysaccharidosis. I just have a few doubts, Dr. Mala. So based on your short stature exam, assessment, the maneuver, what type of short stature do you think this patient has?
Proportionate short stature is there.
Why do you think it is proportionate?
Disproportionate short.
Disproportionate. Okay, yeah, it was very, very good. It was disproportionate short stature. What type was it? Was it short trunk or short limbs?
Yeah.
What type of disproportion did you find out on examination?
Because when I said the Jake to put your arms below, so his arm on the knee.
Yeah, it was almost reaching the knee. That means what is it short trunk or short limbs?
And he's on the wheel.
Okay, usually in mucopolysaccharidosis, you'll have short trunk. Okay, that is why there is overshooting of the hands because usually you'll expect the hands to go reach around the mid thigh of us, of the children whenever you are examining because the hands are almost reaching the knee. That means that the child has short trunk and that is why the hands are almost reaching, below. It is going lower. And so that is the type of disproportionate short stature that you will find in mucopolysaccharidosis. It is usually disproportionate short stature with short trunk in mucopolysaccharidosis. That will be your interpretation. Usually that will be a discussion question. They want to know what have you interpreted from your examination. So along with the examination, you'll also have to read about the interpretation. Like if this is the finding, then what will it be? You do this to find out if there is rhizomelic shortening or not. If at all there is, overshooting or undershooting, based on that, because in skeletal dysplasias, there can be rhizomelic shortening. And hence there will be differences. Similarly, you do a star, see if there is any short fourth and fifth metacarpals, which is usually observed in Turner syndrome or pseudohypoparathyroidism. Similarly, cubitus valgus is a clinical.
And pseudohypoparathyroidism. Yeah.
Yeah, cubitus valgus is a clinical clue for Turner syndrome. Like that, your short stature maneuver, each one has its own interpretation. So you must be very familiar with it so that you'll be able to answer the question. Like I said, short trunk and disproportionate short stature is finding in mucopolysaccharidosis, and you're also very able to pick up scoliosis. No matter what, in almost every system examination, back examination is very important. For CNS, you can pick up spina bifida or kyphoscoliosis. In CVS, you will be able to auscultate murmur or basal crepitations, and if at all there is pulmonary congestion. In RS, you would want to auscultate. All your findings comes from the back also. In your abdomen also, you would want to do back examination, especially for renal angle tenderness or palatability of kidney, whatever you want to find out. So in every system, back examination becomes very important. And in your MSK, you will have some scoliosis or any other musculoskeletal findings. So in every system, you should not forget to do a back. And Dr. Mala was very prompt in checking the back, and that's how she picked up the scoliosis also. It was all very good.
Thank you,
One
ma'am.
thing, very important thing, as soon as you find out that it is mucopolysaccharidosis, what you should not miss is check for corneal clouding. I think that alone you missed when you were checking for eyes, no, for
Yeah,
pallor.
corneal colosis.
Yeah, you should
Hmm.
also put in a light and see if there is any corneal clouding or not.
Yes, ma'am.
Because it's a very common finding in MPS. The most common type of MPS has corneal clouding.
Type 1.
Yeah. If you find that the child is short and your command is general physical examination and proceed, you can definitely do short station maneuver there. Because this is
Yes, ma'am.
other
Thank you.
station, you won't know exactly what type of system examination that you will have to do. So as soon as you find that the child is short and that there is some dysmorphic features, you can ask the examiner that you want to do short station maneuver and proceed. If the examiner agrees, then you can do that. Sometimes they'll say, no, you don't have to do that. You do some other system examination. So then you'll have to find out what system is relevant for the child's findings and then do accordingly. Sometimes they can have a neck swelling, thyroid swelling. So then you'll have to do thyroid examination along with checking for thyroid status. So like that, it will vary. Okay, and one very important
Okay.
question is follow-up of the child. This is again from UK guidelines only. So for all patients, you'll have to check for pulmonary study, sleep study, functional mobility scale, especially because they'll have lots of contractures and deformities. Similarly, you would want to do echocardiography, blood pressure, and ECG measurements. Then, so this is for cardiac. This has to be done annually. In neurological disease, for all patients, you would want to do head circumference, if at all needed neuroimaging with a baseline and every 1 year or 1 to 3 years as indicated. Similarly, especially important is craniocervical junction imaging because they can have atlantoaxial instability. That is a very important thing. So as soon as you said X-ray, I thought you were talking about this and I was about to appreciate you. But then you said chest X-ray, so I couldn't talk about it more, discuss about it more. But then this is very important. When you talk about follow-up plan, you should tell about cervical spine X-ray because there can be atlantoaxial instability in them. Similarly, neurophysiology, neuropsychometric assessment, EEG, if at all needed, all these are to be done annually. Then orthopedic screening will be doing bloods for vitamin D and bone biochemistry like calcium, alkaline phosphatase, and phosphorus, which is annual. DEXA scan, if at all indicated. Then joint imaging, if needed. And in ophthalmology, you'll have to assess for visual acuity, especially because there can be corneal clouding, optic nerve health, corneal pathology, any raised intracranial pressure, or retinal dystrophy, or retinitis pigmentosa, again annually. Then audiometry has to be done annually because they can have conductive hearing loss because of recurrent ear infections.
Yes, ma'am.
Or they can per se have sensorineural hearing loss because of the disease itself. So you'll have to do annual audiometric assessment. And also from ENT point of view, RV assessment, because like you said, there can be nasal polyps also, or there can be constant nasal discharge and upper airway obstruction because of adenotonsillar pathology. So may include airway imaging annually. Sleep study has to be done. Like you said, there can, because of short neck and the adenotonsillar pathology and the upper airway obstruction, there can be obstructive sleep apnea. Then for growth, anthropometry has to be done in every clinic visit because they are syndromic, no? They are short, they don't grow that well. So anthropometry is very important. Similarly, for functional health and well-being, MPS HAQ questionnaire has to be done annually. When do you want to stop? ERT is enzyme replacement therapy. So this is quite a complex thing. Management of mucopolysaccharidosis usually involves enzyme replacement therapy, or it can even be bone marrow transplantation
One
depending on the
transplantation.
stage. Okay, so that again, so management gets into detail. Anyways, you won't have enough time for getting into detail about management in clinical station. Any other doubts anyone has?
Ma'am, we have
Madam?
to carry on torch with us to see
Yeah,
the
you don't have to take any instruments. If at all you're comfortable with a stethoscope, you're allowed to take a stethoscope. But then whatever instruments are needed for the clinical station will be kept inside the room in a tray. You can utilize whatever you need. It will be there. You can utilize from that.
for to see the cornea. I will ask the examiner, sir, I want to see the cornea with torch,
Usually
right?
next to the patient, there will be a tray or whatever, or on a table, all the instruments will be kept. So you can see that, and usually there will be a torch. So you can take the torch from there and you yourself can visualize. Because anyways, this is general physical examination. So whatever findings you want to pick up, you can definitely do and pick up.
Okay, ma'am. Thank you.
Yeah, thank you. Yes, Dr. Mala, you had something to ask?
Yeah, ma'am, I have a question other than this case. If
Sorry,
patient
your
is
voice.
6 months, is
Hello.
abdominal examination, so we have to and abdominal examination
I'm sorry, your voice is breaking. I don't know if
percuss it or not.
yeah, everyone feels that your voice is breaking. Your internet is slow, doctor. You can even type and post in chat if at all your network is an issue. You can post in chat. I can reply from that.
Okay, ma'am. I will check.
Yeah. Thank you, Dr. Mala.
Thank you, ma'am.
Okay. Any doubts anyone else has?
Excuse me, ma'am. Can we just quickly go through the investigations advised?
Yeah, we just saw that, no, all the follow-up, what all investigations to be done. You want me to repeat the slides? I can do that. So for cardiac, it will be
This is
ECG.
a follow-up, no, ma'am?
Yeah, yeah.
But when we discuss after the DTs, then how would you like to investigate?
Oh, okay. As a discussion part. Okay, fine. So for
Yeah.
investigation, like Dr. Mala said, it will be glycosaminoglycans that you want to test. Gene testing will be very important. Enzyme assay can also be done in fibroblast, cells. So these three will be important. Usually in clinical station, because you only have like 3 minutes for discussion, you will have to first put up your definitive investigations followed by supportive investigations. So you don't have to start with CBC and all. You'll directly go into definitive investigations like urinary glycosaminoglycans. Then you want to do gene testing and enzyme assay. And other than this, I also want to do supportive investigations like that. You can start. So that if at all there is a lack of time, the examiner will even cut you. They won't want supportive investigations. They'll take you into management plan. If there is time, they'll let you discuss about the other supportive investigations.
Yes, ma'am. Thank you.
Thank you. So some of the queries are there in chat. If the child's age is 6 months old and the command is abdomen examination, then do we have to percuss the abdomen or not? So usually, if you're lucky enough, you won't get an infant in your clinical station, because obviously infants it's very difficult to make them cooperate. They can be they can cry even if you just touch. So if you're lucky enough, usually you won't get an infant. But beyond that, if you still get an infant, the first thing will be not to fuss them up, not to make them cry, not to cause any pain to them, not to irritate them. That will be the first thing. So usually what we say in infant examination is do of auscultation first, because if the child is crying, you won't be able to hear anything. If the child is calm, then you can ask the examiner that because it's an infant, I want to finish off auscultation first and auscultate the child first. After that, just quickly do an inspection as long as the baby or the infant permits you, and then do a quick palpation. If you feel that the child won't get irritated, or if there is very obvious ascites that requires definite percussion, then you can proceed with percussion. Or if at all it agitates the child, then you'll have to immediately stop it. But per se, for abdomen examination, for you to stick to the structure of examination, percussion has to be done. You'll at least have to attempt if the child is calm. If the child becomes irritable, then you can tell to the examiner that because the child is crying, you don't want to further agitate the child by doing percussion. If the examiner is okay, then you don't have to proceed. But if the examiner still says no, do the percussion, then you will have to do it.
Yes, thank you, ma'am.
Yeah, thank you. So do we need to tell which type of MPS? Usually no, because clinically it is very difficult. But if at all there is obvious corneal clouding, then they might ask you because it's the most common, type of MPS. So then because there is corneal clouding, they can even tell you, because there is corneal clouding, now tell me what is the type of MPS?
Hurler, because Hunter is corneal clear.
Yeah, Hurler is the most common one.
Hmm.
Hurl is the most common type of MPS, and it's the most common one that has corneal clouding or ground
Cornea clear.
interference with the cornea. It is type 1 MPS. Yes, that is very good. That's right. There can even be, grades of corneal clouding. Grade 1 is said to be normal cornea. Grade 2 is there will be mild opacity. Grade 3 is opacity that interferes with vision. And grade 4 is where the opacity is too much that you cannot even look at the fundus. The fundus cannot even be evaluated. So these will be grades of corneal clouding. I'll share this in the group after the session is done. So DDs, as it was discussed, will be mainly infiltrative disorders. I can mention any infiltrative disorders like Dr. Mala did. She gave up mucopolysaccharidosis as a top differential, followed by gangliosidosis. I would also done the same thing. And then since there is co-species, hypothyroidism will be your next differential. Usually 3 to 4 differential diagnosis should be okay. So these must be okay. Other than this, if the examiner expects even more DDs, then you can give DDs for your hepatosplenomegaly because the only examination that you did was abdomen here. Sorry, short stature with hepatosplenomegaly, you can say that it can be metabolic causes or it can even be any hemolytic anemia, all those differentials it can give. And then say that these are unlikely compared to mucopolysaccharidosis. That's why you've kept your mucopolysaccharidosis as your top differential. If they ask you positive findings for mucopolysaccharidosis from your examination, then you can tell disproportionate short stature is there. You were able to elicit that the child has short trunk from your short stature maneuver. There is a cause facies that is again for mucopolysaccharidosis. If at all there is corneal clouding, that again is a point. Along with the child might also have like claw hand or any other contractions or deformity. The child will also have wadding gait if at all you make the child walk. So these all can be supportive points. Someone has asked, please share the investigation slide. Is it follow-up that you're asking, or is it for the diagnosis that you are asking? Please put that in chat so that I can share accordingly. Yes, Dr. Tasnim.
Ma'am, decreased level of mentation also is one of the features of MPs.
Yeah. That also you
That
can
also
tell.
we can
Because
tell.
when Dr. Mala tried to interact with Jack did not respond. Even when she
Yes,
told to open the mouth, the child was not, cooperating. The Mala had to do it on her own, after getting the mother's permission. So all this is a clue for submentation, which again points to any syndromic cause for the all the findings like mucopolysaccharidosis. Yes. Okay, sure. I'll share it. For diagnosis, what all investigations to be done, I'll share that. Yes. Any other doubts anyone has? We just have one more clinical case to do. Anyone else wants to volunteer? Yes. Just one more station and then we can wind up. Anyone wants to volunteer? Or can I randomly call someone?
Ma'am, if anybody don't want to do, then I can do again.
Yeah, so Dr. Samsu Saman is so enthusiastic now. Anyone else as enthusiastic as him? Or shall I give it again to him only?
Ma'am, shall I volunteer?
Dr. Sandhya is Dr. Sher. Sorry, Dr. Samsu Saman. Someone else has volunteered, so maybe next time.
No problem. It's okay, ma'am. It's okay, ma'am. Thank you.
Thank you. Okay, so again, the same thing, 9 minutes for you to do the station. Your time start now. So this is a 17 months old boy, Dev. Examine his respiratory system.
Okay. I enter the station. I hand over my mark sheet. I wash my hands. Then I introduce to the mother. Hello, mom. I'm Dr. Sandhya, one of the pediatrics doctor here. Today, I'm hereby to examine your baby. Is that okay with you?
Hello, doctor. Sure, doctor.
Yes, I'll just have a look. Is baby in the mother's lap or where he is now?
Yeah, Dev is sitting on his mother's lap.
So as he's comfortable, I'll examine him in the mother's lap itself. So, firstly, I would like to, I just want to interact with him. And how does he respond to the interaction? He's smiling or he's not
Yeah,
looking?
he's smiling slightly and then he looks at his mom.
Okay, ma'am. Just having a quick look around. Are there any devices around him?
No, no devices.
Okay, ma'am. Is he any distress? Obvious distress?
No, he's not in any distress.
He appears to be well grown to his age.
Yeah.
And any dysmorphic features?
Whatever you can see in the picture.
Okay.
Consider that both are of the same child.
Yes.
Both pictures of the same child.
Yes, ma'am. Okay, then I'll just go to the baby. As he's a 17-month-old child and I won't want to disturb him, I'll start with the auscultation first.
Sure.
So first I'll take my step and I'll start auscultating in the supraclavicular area. How is the breath sounds?
Yeah, bilateral artery is present. You can hear vesicular breath sounds.
And in the other areas like intrascapular, mammary and intramammary on both the sides?
Yeah, so on the right inframammary region, you can hear that the artery is slightly reduced and you can hear crepitations.
Right intramammary. Okay, in the axil and both the sides axillary and intraaxillary?
Yeah, otherwise in all other areas, artery is heard well.
Okay, ma'am. So then I would like to then check his I will keep a quick look on his chest. Are there any scar from top to bottom? Are there any scars?
No, no scars in the chest.
Okay, then I would see if and any increased precordial activity is there.
No, no obvious
Pulsations over the chest.
Sorry, what over the chest?
Any pulsations over the chest? Visible
No.
pulsations? Any and any obvious deformity of the chest?
No.
Then if he is comfortable, then slowly I would put my hands over both my hands over his chest, and while he's taking his breathing normally, I would like to observe if it is expanding normally.
Yeah, you can see there is slightly reduced, expansion just below the nipple around the inframammary region.
Okay, ma'am. Then I would then just observe if I'll start with the general examination. I'll just look at his palms slowly. I would take his palms on my hand and without disturbing him, I will see if there is any visible pallor or cyanosis.
Yeah, you can see that there is slight pallor.
Okay. And is there any clubbing? As I cannot ask him to do, I just look at his fingers.
No, no obvious clubbing.
Okay, then I'll move above. Any cannulation marks are there?
No, no cannulation marks.
Then I would go above to see, just lift slowly his arm and see if any arm swellings in the armpit.
No.
And any obvious swellings in the neck?
No.
Then
you can see the neck, on the face, whatever you can see in the picture.
Yes, ma'am. Okay. And then I would just quickly, playfully, if he can cooperate, then I would see if pallor is there or not.
Yeah. In the eyes, you're not able to see. In the hand, you can see that there is pallor.
Okay. Then I would also just quickly auscultate for the heart sounds also. I just see in all the areas if any murmurs are there.
You don't hear any obvious murmur.
Murmurs. Okay. Then I would see slowly. I would see below if there is any edema is there.
Where do you want to check?
Yeah, over the lower limbs, if any edema is there, I would check.
No, no.
Okay. Then I would also quickly have a look at his back for any deformities in the back.
No, no deformities in the back.
Okay. Then I would like to summarize, ma'am. Shall I summarize?
Sorry?
I would like to summarize, ma'am.
Okay. Okay. Yeah.
Today I got an opportunity to examine 17-month-old boy who is sitting comfortably, but and he not in any obvious distress and no devices around, but he has some dysmorphic features like large ears, and there is a retrograthia, and there is also depressed nasal bridge and frontal bossing, and I can appreciate a scar on his neck, and then low down there is a decreased air entry in the right intramammary area with crepitations. Also, there is a decreased expansion of the chest there, and there are no obvious murmurs in the heart auscultation, and there is no pedal edema. On examining this, it probably the child is having syndromic features with respiratory infection. These are my findings, ma'am.
Okay, any differential diagnosis that you want to give?
Seeing the dysmorphic features, it could be in the retrograde, it could be Peary-Robinson syndrome. And my second differential, it could be any other syndromes associated with the dysmorphism with
Okay.
the respiratory findings.
Okay, and the infection, what do you think could be the infection?
It could be, man, your voice, I couldn't hear you.
Yeah, you said respiratory infection, no? What do you think could be the infection?
It could be a recent, because he is having retrognathia, it could be some microaspirations leading to infection, consolidation in that area.
Okay, you
And
think it is a consolidation?
it could be a
Hello?
consolidation. Yes, ma'am. Yes.
Okay, okay, fine. So how do you want to proceed with the child? How do you want to manage?
First, I would like to completely, other systems also, I would completely examine the child, plot him on the growth charts. Then also I would take his vitals, vital examinations and blood pressure examination. Then I would review his records previously, what the child has been investigated and what he is on follow-up. Then I would like to proceed with the baseline investigations like complete blood picture, any C-reactive protein if infection I'm suspecting. Then also I would do a chest X-ray if it is previously not done. And I would also see if previously the child is evaluated with any genetic testing and is on any other investigations like echocardiography, any other screening has been done for this child.
Okay, okay. And what do you think could be the cause for a scar in the neck?
That scar looks like a heel scar. It could be a prolonged ventilation where the child must have been having a tracheostomy, and then that's the heel scar of the tracheostomy. It could be the possibility. So I would like to check with the previous records any admissions are there for this baby.
Okay. And how do you want to confirm the diagnosis? You're suspecting a top differential, you said it as a Peary-Robinson sequence. So how do you want to confirm the diagnosis?
Genetic, I would like to involve geneticists and then go ahead with the genetic screening and then confirm the diagnosis. I would also involve my pediatric, myself and my pediatric consultant, then the geneticist, and also on what teams the child is following up and how his nutrition is being met with along with the dietitian.
Okay.
And
Any other investigations that you would want to do?
I would also like to do screening 2D echocardiography for this child if it is not done before.
Okay. Why would you want to do echocardiography?
Though clinically no murmurs are there, but it is a syndromic child, I would like to screen for any unidentified
Okay.
cardiac anomalies.
Okay. Any other investigations?
Apart from this,
Okay. What will be your management plan?
management, I would like to involve the team like myself and my consultant. Then also I would like to involve the geneticist. Then also as he's having retrognathia, he might be having some feeding problems. So the dietitian and the nutrition and support for the child, as this child appears to be syndromic, with the support groups and any other also, if suppose the child is having any chronic chest infection persistently, then the pediatric pulmonologist and with the chest physiotherapy if required.
Okay, fine. Yeah, your time is up. Thank you, Dr. Sandhya.
Thank you, ma'am.
Yeah, thank you. Yeah, so this was Peary-Robinson sequence only. How you picked it up was very good. And like I was just now discussing, because it's a child less than 2 years of age, it's better to auscultate first when the child is calm. So that only you also did, and you were able to pick up findings, and that's how you were able to give a diagnosis that it was a consolidation, probably pneumonia. But other than that, my doubt is that you didn't proceed with your respiratory system examination. You didn't attempt palpation or percussion. Why was that? You could have,
So blood
I know it is an
practice.
infant, you don't want to agitate, but that you can attempt at least palpation. Percussion at least will cause pain because you're, like flicking your finger and all. But palpation is going to touch, and if at all the child is making any noise, based on that, you can even do vocal tremators. You don't have to, like, the child may not obey your commands, the child may not repeat 999 or whatever. But then if at all the child is making any noise or talking with the mother, like whatever
Yes.
developmentally appropriate, then you can definitely try vocal fremitus. What will be your finding for vocal fremitus in consolidation?
Vocal fremitus will be increased.
Yeah, it will be increased. Very good. Yes. So, anyways, yeah. So this was a syndromic child. Peary-Robin sequence will be a top differential, and then you can say any syndrome. Yeah, because for Peary-Robins it is very difficult to give DD, so you can just say any syndrome. So, anyways, for that you'll be involving a geneticist, and there is also someone called dysmorphologist in the UK. So you can involve them also because they'll see the dysmorphism and then they'll give what it could be accordingly, any differentials or whatever. And so other than that, on your multidisciplinary team, everything was very good. You would want to involve a geneticist, your own pediatrician, and then dietitian, and then ENT, pulmonologist, all of them will have to be involved. If at all they ask specific differential diagnosis for Pierre-Robin sequence, like they want you to attempt anything, then you can include Treacher-Collins syndromes, or even the what we call as facial syndrome or charge syndrome. All those can be a differential diagnosis. Facial syndrome usually has 22q deletion, and then charge is also charge
Okay.
variant. So those will be your differential diagnosis. It can even be Stickler syndrome. Pierre-Robin sequence is supposed to be associated with Stickler syndrome. Pierre-Robin sequence per se does not have any genetic test that can, confirm the diagnosis of Pierre-Robin sequence. But then, since there can be associations with Stickler syndrome or any other syndromes, genetic tests can help you, diagnose those syndromes. But otherwise, Pierre-Robin sequence, if it is isolated, usually there won't be any genetic, because it's a sequence, no, it is not a syndrome per se. So there won't be any genetic cause or, gene mutation that you'll be able to pick up on your gene testing. Usually, it is a clinical diagnosis. There is a triad of features that you see clinically. Will you be able to, number them? Which are all the part of triad?
Retrognathia is one.
It's retrognathia or micrognathia. They usually have a very underdeveloped lower jaw. Because of the micrognathia, it looks like that it is retrognathia, that it is, not straight to the maxilla, it's behind. Yes, that is one. Then
tongue abnormalities.
yeah, there will be glossoptosis. Very good. The tongue falls back into the throat because of glossoptosis, and that is a very important cause of upper airway obstruction. They'll always have noisy breathing. They can have obstructive sleep apnea. All this is because of glossoptosis. I didn't want to myself comment that there is noisy breathing. I thought as soon as you saw Pierre-Robin sequence, maybe you'll ask about it if there is any audible sound that you can hear. So that is why I didn't give it away as a clue. But then, anyways, when you're actually examining the patient, you will be able to observe that there is noisy breathing, and you will be able to correlate it obviously.
Okay.
And then the third one is cleft palate.
Yeah.
So again, you can either attempt, examining the mouth by probably putting a tongue depressor, or at least tell that you would expect to see a cleft palate if at all you examine the mouth. But today I didn't do that because I didn't want to agitate the child. Because it's the main triad, no? The triad only gives the clinical clue for diagnosis. So all three has to be there for you to tell Pierre-Robin sequence. For that reason, you can tell that I can also expect a cleft palate to be found in this patient. But since I didn't want to agitate her or him, I didn't, examine the mouth. Like that also you can tell.
Yes.
If the examiner might tell, no, you proceed with the mouth examination. Then you can even ask for a tongue depressor and try examination.
Okay, ma'am.
Okay, and echocardiography, though not, you may not expect it at 17 months old, but like I said, because of obstructive sleep apnea and upper airway obstruction, there can be, cor pulmonary at later stages. For that, echocardiography can help in Pierre-Robin sequence. Otherwise, now, because of the OSA obstructive sleep apnea, sleep study, polysomnography can help.
Okay.
Okay, and ultimately, yeah, like you said, echocardiography for cor pulmonale, and you might require a imaging CT scan or at least a lateral jaw X-ray of the lower jaw of the mandible to see how the jaw structure is, because it can affect the speech and even swallowing part. So for that reason, in your multidisciplinary team, you'll also involve a speech and language therapist.
Okay.
Okay.
Yeah.
Anyways, this child will also have developmental delay, and also you'll also involve a developmental pediatrician.
Yes, ma'am.
Okay. And yeah, so why would you involve the ENT, especially mainly for the upper airway obstruction and for the retrography and glossoptosis? They might do something called the nasopharyngoscopy to visualize the airway, to see which all part of the airway is getting obstructed, because it is upper airway obstruction.
Yes, ma'am.
Okay, so the like you said, rightly said, the scar in the neck is probably the tracheostomy scar. Very good. So they can then ask you about tracheostomy care. Yes, Dr. Farwa, upper airway obstruction can be is usually the indication for tracheostomy in Perry-Robin sequence. Because of the glossoptosis and upper airway obstruction, emergency tracheostomy can be done. Chest findings in the baby, there was consolidation findings, like there was crepitations in the inframammary region, along with decreased breath sounds. Because there is also decreased breath sounds, you can even consider effusion or any other complicated pneumonia types as your differential diagnosis for the chest findings. Because your main command is respiratory system examination, they might expect you to give differential diagnosis for the respiratory findings per se also, other than the syndrome. So, like I was telling about tracheostomy care, this is all what is given. So, where do you do the tracheostomy? It's usually at the third, between the third and fourth tracheal ring. What at parts of the tracheostomy tube? How do you do the suction technique? Usually, you put in the catheter in directly into the tracheostomy, but then it is not. It should not be put very much in, because you can directly touch the airway and agitate the child. Then equipment list for tape changes, because you should always have an emergency box, because when you're trying to change the tape, the tracheostomy might get pulled out. And one more important thing will be checking the tape tension, so that you don't stretch the tracheostomy too much and put it too much in and cause tension for that reason. And what all should be there in the emergency box? Same size tracheostomy should be there, because even if it comes out and you want to put in a new one, that should be a tracheostomy. And a smaller size, because if at all there is granulation tissue formation around the tracheostomy because of prolonged usage, you might require a smaller size tracheostomy. For that reason, you should also have a smaller size along with it. Then tapes, disconnection wedge, scissors, lubricating jelly, then syringes for cuffed tube, then suction catheters. And this is very important. Remember to always know where the emergency box is when caring for a child with a tracheostomy, so that you can immediately go run and get it. Yeah, because even during suction, the tape can come off and all that. So RS also comes in other station. I think among the three that we saw, the first one is a neuro station, motor system examination with DMD. Second and third will come in other station. All the three are recent recalls. All the three have been asked, quite frequently. Especially RS has been, RS is being increasingly asked in other station. Because of that only, these days we are doing quite a lot of RS when we do clinical stations. Anyways, others, mucopolysaccharidosis is a very important other station. It can either be kept in a short stature evaluation alone, then you just do a short stature maneuver, and then you do measurements like height measurement, weight measurement, then upper segment, lower segment ratio, if at all the child is cooperating. Or they can just do a general physical examination alone, wherein you'll have a lot of findings like coarse facies, then claw hand, then maybe carpal tunnel syndrome, and there can be a scar for the carpal tunnel syndrome, or there can be a lot of contractures, or the child can also have waddling gait. Because gait is also part of your general physical examination. If at all you find any positive findings, for example, in this child, you can see that there is coarse faces and then there are other findings. So then you are suspecting mucopolysaccharidosis. And then you are thinking that you want to do abdomen examination, but then the examiner says you don't have to do abdomen examination, do some other examination. Then you can even consider doing a gait examination, because the child can have waddling gait in mucopolysaccharidosis. Other than that, short stature maneuvers, like we already saw, the main finding here will be disproportionate short stature with small trunk. From your maneuvers, that's the finding that you will get. So these are the QR codes for our WhatsApp groups. You guys can scan it or forward it to your friends so that they can join. And do contact us if at all you want to join our course. Please scan the QR code of the group to join in the group. Any one group you can join, that is more than enough. Please scan the QR code for joining the WhatsApp group. You can even take a screenshot and join later. If anyone has any other doubts, you can definitely ask me. Okay, we can probably wind up the session if there's no further doubts. Yeah. Thank you, everyone. Thank you.
Thank you, ma'am.